And my dear students, I welcome you all once again to our Railway RAISA Anesthesia Online Academics, DNB Academics session today. Today we'll start our session with a clinical case and PPT presentation by Dr. Rohan from DNB candidate from Central Hospital, Central Railway, Byculla, Mumbai. This topic will be a 40-year-old female with bronchial asthma for lap cholecystectomy, anesthetic management. Over to Dr. Rohan, please. Please unmute yourself, Rohan.
You can hear, but your voice is little weak. Can you make it little more louder? Increase the volume, please.
Is it audible now, sir?
Yeah, audible.
Yes, sir. Now I would share my screen.
I think you can take off your mask and start talking, because that gives the. Are you?
Yes, sir. I have started sharing my screen. Is it visible, sir?
Yeah, it is visible. Are you a primary candidate or post BA candidate?
I'm a primary junior resident 1, sir. Anesthesia.
Okay. Go ahead.
Yes, sir. So the case given to me was 40-year female with bronchial asthma, posted for lap cholecystectomy, and they have asked for the anesthetic management. And I have made a PPT regarding the implications and definitions of asthma, anesthetic implications. And let me start it with a disclaimer that that resources has been collected from multiple sources, so it is not copyright free. So asthma is characterized by chronic airway inflammation with bronchial hyperactivity. And the key term that distinguishes asthma from the chronic obstructive lung disease is it is reversible in nature. And both small and large airways are affected. The prevalence of asthma range between 4 to 5% of adults and 7 to 10% of children. And approximately 50% patients develop asthma before age of 10. Regarding the predisposing factors of asthma, there are airborne allergens like dust, mites, pollens, etc. And there are pharmacological stimuli like some people are sensitive to aspirin, some beta antagonists, and NSAIDs. And environmental and air pollution are one of the major predisposing factor for asthma, especially in the developed world. Some occupational factors like people get exposed in in wood industry, they get exposed to the wooden dust that that they get from the sawing of the wood, and some infections like respiratory tract disease, syncytial virus, etc. could also trigger asthma attacks. Some people have exercise-induced asthma as well. Regarding the signs and symptoms of asthma, it is characterized by most common symptoms people express is shortness of breath, and on auscultation we can find wheeze, and sometimes when the attack is severe, there can be silent chest as well. So the people express it as chest discomfort, air hunger, etc. They also have palpitation due to the breathlessness they experience. Along with these, some people also have rhonchi. There are basically two types of asthma. One is extrinsic asthma and intrinsic asthma. This is uh, based on the onset of asthma. If it is childhood onset, type 1 hyperreactivity and IgE level associated with allergic rhinitis, dermatitis, then it is extrinsic asthma. And regarding the intrinsic asthma, it is most commonly at adult onset and usually associated with aspirin intake, nasal polyp, and intrinsic asthma, which is called Sanders triad, which has a bad prognosis. Childhood asthma usually has good prognosis, whereas adult onset asthma usually has bad prognosis. So there are two mediators of asthma. Earlier, we only thought that eosinophil is the only cell that initiate asthma, but now it has found that both eosinophil and neutrophil mediated asthma are found, and different medications has been targeted based on the release of the interleukin on which is like if it is eosinophil mediated asthma, then the medications are targeted for interleukin 4, IgE, interleukin 5, and if it is neutrophil mediated asthma, then new medications have been monoclonal antibodies have been targeted as well for that. Regarding childhood asthma, it is found that childhood asthma is seen in people who are in developed countries who has not been exposed to any kind of dust in their lifetime. They have been very protected and kept inside the surrounding of the home. So the theory proposed behind this type of asthma is that when child don't get exposed to the basic environment outside the home, and then their immune system is not sensitized to the outside environment. And when that child grows, when it suddenly gets exposed to outside environment, then this stimulus is being seen as even the normal stimulus like pollens or regular air or bacterial infection can also be like trigger an trigger a raised immune response, which presents as asthma. So based on the frequency of the symptom, the asthma severity has been classified as intermittent asthma, mild asthma, moderate, and severe asthma. If the symptom is less than or equal to 2 days per week, or the symptoms is less than equal to 2 per month, the nighttime symptom is less than or equal to 2 per month, we call it as intermittent asthma. And if the symptom is more than or equal to 3 days per week, or more than or equal to 3 night episodes per month, then we call it mild asthma. And if the daytime symptom is daily present, or more than or equal to 1 per week night symptom is present, we call it moderate. And if the symptom is persistently severe throughout the day and the night symptom is present all over the week round the clock, then we call it severe asthma. GINA 2022 has proposed the latest guidelines, slightly updated from the 2019 strategy for treatment, which involve when people have intermittent or mild asthma, inhaled corticosteroid and formoterol should be started as required whenever there is a need, whenever there is an episode to be given. When there is moderate asthma, then low dose ICS and formoterol, inhaled corticosteroid and formoterol should be taken on daily basis. If it is severe asthma, then a high dose inhaled corticosteroid is indicated on daily basis along with formoterol. And if there is severe persistent asthma, along with the high dose inhaled corticosteroid and formoterol. We add on to specific agents like anti-IgE, anti-interleukin 5, anti-interleukin 4, or we can also add oral oral steroid, or we can also add long-acting muscarinic antagonists. So some of the differentials of bronchial asthma are like patient with bronchial asthma are acute LV failure, which is misnomed as cardiac asthma, upper airway obstruction by a tumor or a foreign body, endobronchial diseases like neoplasm, bronchial stenosis, costenoid tumors, recurrent pulmonary emboli, chronic bronchitis, and eosinophilic pneumonias, etc. So pre-op, when the patient is posted for any surgery, we do a pre-operative investigation for the patient to prevent the patient from the intraoperative hazards. So the most common investigation we do, along with all routine laboratory investigation like CBC. CBC can show you eosinophil. If the some patients like eosinophil mediated asthma, they have increased eosinophil, and chest X-ray can be done. And what we see in chest X-ray is typically due to air trapping. We can say hyperinflation of the lungs. And along with it, we can also do 2D echo to rule out the cardiac causes of dyspnea. And the most important thing, if the patient is a known case of asthma, most important thing is to do a PFT and to check regarding the percentage of reversibility after the PFT. And baseline ABG to be done before taking the patient to the OT in order to see whether the patient is having hypercapnia, whether he is an impending respiratory failure, whether the patient is on type 1 respiratory failure or not. Most common in asthma is type 1 respiratory failure, which is usually hypoxemia. But when the symptoms are severe, we can also find type 2 respiratory failure. When the patient on long-standing severe asthma, we can see type 2, where there is also hypercapnia, since the carbon dioxide cannot be exhaled out from the lungs along with the hypoxia. Post expiratory FEV1 and MMEF are measured. FEV1 is the most sensitive test, where we ask the patient to have a forceful expiration and check the spirometry, the loop especially for the first second. We will see slightly more detail about it on the upcoming slides. FEV1 is used to assess the severity and monitor the course of exacerbation of asthma. Usually, total lung capacity remains within normal range. Asthma is usually the disease which doesn't have any effect on the volume. It only has the effect for expiration. The patient cannot take in oxygen due to bronchoconstriction. So when we see the flow volume loop, we can see the normal flow volume loop, and when the flow volume loop starts from here, this is the inspiratory curve. This is the normal inspiratory and expiratory curve, and we can see scooped out appearance of patient with asthma or any chronic obstructive lung diseases, where the inspiration is normal, but during expiration there is a scooped out appearance because the patient is not able to expire a sufficient volume. And this loop shows a patient with pulmonary fibrosis with restrictive diseases, where the inspiration and expiration curve appears to be normal, but the volume is significantly reduced. And closing capacity is one of the important terms we should learn. It is the lung volume at which the small airways in the dependent part of lung begin to close. So when the FRC is less than the when FRC is less than the when the FRC is less than the when less than the CC, then it means the lungs can get easily collapse. They are prone to collapse. The alveoli are prone to collapse. So we can see that at the age of at the normal person, CC and FRC are equal. At the age of 44 in supine position and at the age of 66, they will be equal. But as the age increases, we can see that the closing volume abruptly drops down when the patient is on lying down position. Whereas at the 66 year, we can see that even at the sitting position, the closing volume gets like the lung gets easily collapsed even on sitting position. The thing we can conclude from this diagram is that at the age of 44, the lung can withstand. The lung gets collapsed, the alveoli gets collapsed only on lying down position. But as the age progresses, when the FRC reduces significantly, the lung gets collapsed even when the patient is on sitting position. So this thing should be considered during our anesthesia, because during the when the patient is kept on ventilator, and especially if the age of the patient is more than 65 years patient, then we should maintain a PEEP pressure to keep the airways persistently open. If it is not, if the adequate PEEP is not provided, then there is a possibility that the dependent alveoli gets collapsed. So when FRC is less than CC, airway close in the dependent parts of lung during the certain periods of normal tidal ventilation collapse. So due to the collapse, we may have shunting of the blood and there may be ventilation perfusion mismatch. This is a similar slide which this is the similar detail given that during general anesthesia, the cross section area of the rib cage decreases by 200 ml. And FRC also decreases by 30 ml. The spontaneous breathing FRC decreases by 20%, and on artificial ventilation, FRC decreases by 16%. So what will be our preoperative preparation for the asthmatic patient with COPD or with patient with asthma or COPD? The goal of the preoperative evaluation is to formulate the anesthesia plan that prevents or blunts the obstruction to expiratory flow. So we do a chest X-ray, we do a PFT, and we also check for the response for the bronchodilator. We do a baseline ABG. We check for the history of allergen. We check for the symptoms and signs of cardiac or respiratory failure carefully. The goal is as such, like to eradicate the acute or chronic infection with appropriate antibiotic, relief of bronchial spasm with adequate bronchodilators, chest physiotherapy to improve sputum clearance and bronchial drainage, and reversal of uncompensated or borderline core pulmonale with diuretics, digitalis, improved oxygenation and correction of acidemia. On physical examination, we can see if the patient is having a severe episode, we can see the patient is using accessory muscle for respiration. And we can, on the auscultation, we can see wheezing, we can see rhonchi, and on blood investigation, we can see eosinophil counts gets elevated. And on PFT, we can see FEV1 is significantly reduced, which is less than 70%. FE and the FEV1 and by FEC ratio is less than 65%. So we have already seen chest physio, antibiotic bronchodilator therapy pre-op to be done for the patients with bronchial asthma. Cessation of smoking for 2 months will improve the mucociliary clearance and decrease the sputum production. And at least cessation of smoking for 2 days, for at least for 12 hours, will reduce the carboxyhemoglobin significantly, which can indeed increase blood oxygenation content and release of oxygen in the hemoglobin. Poorly controlled asthma will need supplemental glucocorticosteroid administration. It could be IV hydrocort 100 mg every 8 hourly or oral prednisolone 40 mg once daily for 5 days before the day of surgery. For minor surgery or surgery under local anesthesia, no extra supplementation of steroid is required. For moderate surgical stress, like example, low extremity revascularization or total joint replacement surgery, should take usual morning dose, which is 50 mg IV hydrocort before the procedure and 25 mg of hydrocort every 8 hours for 24 hours. For major surgical stress procedures, for the surgery with major surgical stress, we give 100 mg of IV hydrocort before induction of anesthesia and 50 mg every 8 hours for 24 hours. And later on, we taper the dose half per day to maintenance level. It has been found that URTI, preoperative URTI, especially in children, increases the risk of postoperative pulmonary complication at 11-fold. And Tate and Knight found that laryngospasm and bronchospasm are significantly increased even in healthy children 2 weeks after URTI. So it is recommended to wait for 2 to 3 weeks once the child with asthma has URTI. So intraoperative, now we come to the intra-OT management. So we pre-medicate the patient with, we nebulize the patient with beta-2 agonists like salbutamol, like 20 to 30 minutes prior to taking the patient to the bed. And we pre-medicate with midazolam, fentanyl to prevent the patient's anxiety and reduce the pain, which might in turn trigger the respiratory. When the patient is anxious or experiences pain, asthma episode can be triggered. To avoid it, we pre-medicate with midazolam and fentanyl. So anticholinergic medications like glycopyrrolate 0.2 mg or atropine 0.4 mg can be used to reduce the secretion and reduce airway vagal responses. And this should be avoided in patient who has tachycardia. If the patient has significant attack while the patient is taken on OT table, the elective surgery can be postponed. If it is an elective surgery, the patient can be the surgery can be postponed and can be rescheduled once the patient becomes medically stable. If it is an emergency surgery like acute appendicitis, surgery performed after the asthmatic attack is terminated with medical management. The main aim is that airway reflexes must be suppressed to avoid bronchoconstriction in response to a mechanical ventilation of hyperactive airway. Usually, we induce the patient with propofol because it has significant, the propofol significantly suppresses the airway reflexes, and thiopentone is avoided since it incompletely blunts the airway reflexes, which might trigger an episode of acute asthma attack. Ketamine has bronchodilator properties. Ketamine is also preferred for the patient with known case of asthma. But the drawback with ketamine is we all know that it increases the airway secretion. It can increase the blood pressure. It can produce tachycardia. It can increase intracranial pressure. It can increase intraocular pressure, etc. So especially since it increases the airway secretions, we prefer propofol more than ketamine for induction of the anesthesia. Etomidate is another option, but it lacks the bronchodilatory effects as propofol. When the patient is hemodynamically unstable, if the patient is in core pulmonale, or if the patient has a history of recent myocardial infarction or any cardiac history, then etomidate can be preferred, since the propofol has also cardiosuppressant action. Neither etomidate nor thiopentone prevents wheezing after intubation, as opposed to the marked protection afforded by the propofol. We have seen that ketamine produces bronchodilation both through neural mechanism and through release of catecholamines. In an actively wheezing patient, ketamine is the induction agent of choice, particularly when the hemodynamics are unstable, especially if the patient has hypotension. Ketamine-induced bronchodilation may not be as pronounced as that of propofol. We can give intravenous lignocaine 1 to 1.5 mg per kg, 1 to 2 minutes prior to intubation to prevent reflex-induced bronchospasm. Topical endotracheal spray of lignocaine must be used cautiously, which must be avoided because it might also provoke bronchoconstriction. Lidocaine infusion 1 to 2 mg per kg per hour may be used in cardiac or elderly patient with COPD. While coming to the muscle relaxant, we have histamine. We have some muscle relaxant, some muscle relaxant which release significant amount of histamine, like atracurium and mivacurium. So atracurium and mivacurium should be avoided in patients with asthma, whereas cis-atracurium, vecuronium, ropuronium can be safely used. While coming to the maintenance of anesthesia, the goal is to establish depth of anesthesia sufficient to decrease airway reflex, so that bronchospasm is to avoid bronchospasm. So we can use sevoflurane or halothane, since both of these inhalation agents are less pungent, and it can produce less cough and risk of less bronchospasm. Sevoflurane, halothane, or isoflurane are bronchodilators. It can decrease airway responsiveness and attenuate bronchospasm. Clinical observation in human indicate that sevoflurane at 1.1 MAC may be the most effective agent, particularly in presence of airway instrumentation. Sevoflurane has more rapid onset of bronchodilation than isoflurane and halothane. Whereas desflurane is pungent smelling, and it can increase the secretion, coughing, and it can increase the risk of laryngospasm. It causes increased airway resistance when compared with sevoflurane and isoflurane, especially in current smoker. While you are maintaining the patient, the signs of bronchospasm under anesthesia are as such. We can on monitor we can see the upsloping of EtCO2. We can see the sharp finning of EtCO2, appearance of EtCO2, and we can, on auscultation, we can hear a wheeze. We can see that when based on the severity, we can see the EtCO2, the carbon dioxide EtCO2 waveform is decreased, and we can see if the bronchoconstriction is severe, tidal volume can be reduced, and the high inspiratory pressure might be indicated. The saturation, oxygen saturation will also decrease. So when we see a patient undergoing a surgery, in this case lap cholecystectomy, having a episode of bronchoconstriction intra-op, first of all we should rule out the other causes of the rule out other possible causes. Like a king DT tube can also give a sharp thinning, and the peak pressure could we can also find the inspiratory pressure find to be increased in king DT tube as well. Or during positioning, there is a possibility that the tube goes into bronchus and endobronchial intubation can happen. Unilateral lung intubation can also increase the pressure inside. And aspiratory pneumonitis, pulmonary edema, tension pneumothorax can also mimic bronchial asthma. So first of all, we should rule out by auscultating and giving a trial of bronchodilator. So the management is 100% oxygenation and hand ventilation. If it is mild bronchospasm, deepen the anesthesia bolus with IV propofol or ketamine. Increase the concentration of volatile agents, and if the bronchospasm persists, short-acting beta agonists like salbutamol can be given. 8 to 10 puff of the salbutamol to be given, because there is a lot of dead space, and there is a possibility of condensation of the drug in the ET tube itself. In normal circumstance, we advise only 2 to 3 puffs of bronchodilator salbutamol. If there is a severe bronchospasm, magnesium sulfate 2 gram IV over 20 minutes can be tried, and if it is still persistent, adrenaline IV bolus 10 to 50 micrograms can also be tried. Extubation plan for the patient with bronchial asthma should be deep extubation, where we make sure the patient is awake, whereas before we don't let the patient to come out of the anesthesia plane completely, and we also make sure this by giving a puff of salbutamol metered-dose inhaler, and we try to remove the ET tube like 0.5 centimeter at once, and then see whether the patient is experiencing any difficulty in breathing, or whether he is dyspneic, and we extubate the patient while the patient is already sedated, and we monitor the patient in the post-operative ward for the complications. In post-operative period, we make sure to give adequate pain control, bronchodilator therapy, and incentive spirometry, and deep breathing maneuvers, and early mobilization to avoid the post-operative pulmonary complication. Normally, in post-operative ward, if the patient after extubation, if the patient had an sudden exacerbation episode, we can give O2 inhalation up to 6 liters per minute along with the salbutamol. We can also add ipratropium. If we can add IV aminophylline 6 mg per kg, bolus can be given, can be run as an infusion as well at 1 mg per kg per hour. If the patient is not yet settled, we can give IV hydrocod 100 mg, and we can at the last we can also try magnesium sulfate 1 to 2 gram over 20 minutes. And if the patient is still unresponsive to the treatment, we can consider mechanical ventilation of the patient and intubate him. Thank you.
Congratulations. Is this the first time you are presenting?
Yes, sir.
Did you prepare the whole PPT by yourself or you were guided by your seniors?
I did prepare it by looking multiple videos and yeah, the basic knowledge came from my obviously from my professors and my consultants.
Very good.
During my posting in the operation theater. Regarding this PPT, I have checked some resources and books, reference, and made my conclusion.
Very good. Okay. It was a very, very bold and very lucid presentation, suitable for a paper to be presented in CM. Okay. You
Thank
can
you.
close your screen. You can now go to. So, but the question that we